Hello everyone, welcome to Pediatrics and Neonatology. This video is about neonatal hypocalcemia. Calcium concentration in the immediate newborn period decreases in all newborn infants. The concentration in the fetal plasma is higher than that of the neonate or adult. Hypocalcemia is a total serum calcium concentration less than 8 mg per deciliter in the term infant or less than 7 mg per deciliter in the preterm infant. It is also defined as an ionized calcium level less than 3 to 4.4 mg per deciliter depending on the method, that is, type of electrode used. Symptoms and signs of neonatal hypocalcemia rarely occurs unless total serum calcium is less than 7 mg per deciliter or the ionized calcium is less than 3 mg per deciliter. Signs include hypotonia, tachycardia, tachypnea, apnea, poor feeding, jitteriness, tetany, and seizures. But similar symptoms may occur with hypoglycemia and opioid withdrawal. Now, hypocalcemia tend to occur at two different times in the neonatal period. First is early onset hypocalcemia. This occurs in the first 2 days of life. Risk factors for the early onset hypocalcemia include prematurity, being small for gestational age, maternal diabetes, and perinatal asphyxia. Now, mechanism vary. Normally, parathyroid hormones help maintain normal calcium levels when the constant infusion of the ionized calcium across the placenta is interrupted at birth. A transient relative hypoparathyroidism may cause hypocalcemia in preterm neonate and some small for gestational age neonates who have parathyroid glands that do not yet function adequately. Hypocalcemia due to a transient relative hypoparathyroidism may also occur in infants of mothers with diabetes or hyperparathyroidism because these women have higher than normal ionized calcium levels during the pregnancy. Perinatal asphyxia may also increase serum calcitonin, which inhibit calcium release from the bone and result in hypocalcemia. In other neonates, the normal phosphaturic renal response to the parathyroid hormone is absent and the elevated phosphate level lead to hypocalcemia. Now, the late onset hypocalcemia. This occurs at approximately 7 to 10 days of life. The cause is usually ingestion of cow's milk or formula with a too high phosphate load. Elevated serum phosphate level lead to hypocalcemia. It is also observed in infants with hypoparathyroidism, which occurs in D-George syndrome, which is 22q11 deletion. Now, mothers in third world countries often have vitamin D deficiency, which can also contribute to late onset hypocalcemia. Now, the diagnosis of neonatal hypocalcemia is by measurement of total or ionized serum calcium levels. Ionized calcium is more physiologic measurement because it does not require correction for protein concentration and pH. Prolongation of the corrected QT interval on the ECG also suggests hypocalcemia. Now, the treatment of neonatal hypocalcemia. Early onset hypocalcemia ordinarily resolve within a few days. Asymptomatic neonates with serum calcium level more than 7 mg per deciliter or ionized calcium more than 3.5 mg per deciliter rarely require treatment. Those term infants with levels less than 7 mg per deciliter and preterm infants with serum calcium level less than 6 mg per deciliter should be treated with 200 mg per kg of 10% calcium gluconate by slow IV infusion over 30 minutes. Too rapid infusion can cause bradycardia, so heart rate should be monitored during the infusion. The IV site should also be watched closely because tissue infiltration by a calcium solution is irritating and this may cause local tissue damage or necrosis. Manifestation of the calcium infiltration include skin redness, calcification, and necrosis or slough. There can be radial nerve damage at the wrist. Now 10% calcium chloride 20 mg per kg or 0.2 ml per kg per dose may result in a larger increment in the ionized calcium and greater improvement in the mean arterial blood pressure in sick hypocalcemic infants, and thus may have a role in the newborn. One important thing to remember is that calcium salts cannot be added to IV solution that contains sodium bicarbonate because they precipitate as calcium carbonate. Now, after acute correction of hypocalcemia, calcium gluconate may be mixed in the maintenance IV infusion and given continuously. Starting with 400 mg per kg per day of calcium gluconate, the dose may be increased gradually to 800 mg per kg per day if needed to prevent a recurrence. When oral feedings are begun, the formula may be supplemented with the same daily dose of calcium gluconate if needed by adding the 10% calcium gluconate solution into the day's formula. Supplementation is usually required for only a few days. Late onset hypocalcemia treatment is addition of calcitriol or additional calcium to the infant formula until normal calcium levels are maintained. A low mineral formula including low phosphate as for infant with impaired renal function may be helpful. Oral calcium preparations have a high sucrose content which may lead to diarrhea in the preterm infants. Now the prognosis is good for the neonatal seizures entirely caused by hypocalcemia that is promptly treated. Okay friends, thanks for watching. Please like, share, comment and subscribe to my YouTube channel for more informative health videos.